All right, so let's talk about intracranial hemorrhages. And there's a few situations that make us think about maybe an intracranial hemorrhage as opposed to an ischemic stroke, which is what we have been talking about. So if someone comes in with a severe headache, they've had altered mental status, so they're confused or they're just completely out of it, and they have something called meningismus. So basically neck pain, or they try to bring their chin to their chest, they can't do that because of pain. If they have emesis, or they have nausea and they're throwing up, or if they have a focal neurologic deficit like a seizure or something else, then we wonder a little bit about an intracranial hemorrhage. Other things that make you worry about that, if they have an extremely high blood pressure, like 220 over 110, something like that, and higher, and I've seen as high as 250s to 300s in the systolic range, you worry about that. If they're on any of the anticoagulants that we just mentioned, Coumadin, some of the newer ones, you worry about that. And if they have some other connective tissue diseases, Ehlers-Danlos, polycystic kidney diseases, there can be some vascular abnormalities associated with that. The workup that we do, once the patient comes in, we're worried about that. We do a quick history and physical. Obviously, we ask them about medications, including medications that may not be legal, shall we say. And then we want to do some head imaging, right? So a CT, which we can show over here. All right. And the CT, which we talked about during the Essentials of Neurology talk, it's nice to do that because it's quick. But if you want to get a closer image, maybe you get an MRI as well. And then if you want to get a look at the blood vessels because you're worried about an aneurysm, which we'll talk about later on, then you'll probably get some sort of vessel imaging, most typically a conventional angiogram or a CT angiogram. So some of the things to look at. So we'll talk now about some of the causes of intracranial hemorrhages and the pathology of some of these findings. We probably won't spend much time talking about the traumatic causes. I think there's a separate lecture for that. But today we'll be spending time talking about some of the vascular pathology of that. Dr. Gokten, do you have anything that you want to say before we move into the next image?
A lot, actually, but how much time do we have? No, just kidding. Yeah, one thing I really want you guys to be able to say at least, oh yeah, I heard of that, is something, terminologies may have changed over time, but malignant hypertension, which probably Dr. Mazankai just described, really high blood pressure, and hypertensive encephalopathy. We have two major reasons for a spontaneous, if you call it that, intracranial or intraparenchymal hemorrhage. Most common cause of an intraparenchymal hemorrhage is hypertension. The second most common cause is cerebral amyloid angiopathy, and I will explain those. And of course, one can have a vascular malformation, one can have some kind of a metastatic tumor that is prone to bleeding, such as metastatic melanoma. It's famous for presenting first time, in fact, with a stroke. On the other hand, subarachnoid hemorrhages are, until proven otherwise, are related to an aneurysm rupture. There are other involvements of subarachnoid space by varying degrees of blood. Usually those are mild and as part of a larger picture, such as coagulative disorders or some hematolymphoid like leukemic infiltrate involving the subarachnoid space, or sometimes an intraparenchymal hemorrhage will dissect into the ventricular system and come back and show up in the subarachnoid space on the brain surface. And this gives you a good opportunity to review your CSF circulation anatomy. But so let's move on to next slide and see what we see. How do I know this is hypertensive hemorrhage? Just by the odds. In general, you may be shown some gross pictures, pathology pictures like this of the brain. And to understand where you are, check the relatively normal looking side. And in this case, we're in the thalamus. So therefore, we have a thalamic hemorrhage, which apparently extends into the lateral ventricle. Hypertensive hemorrhages, most common places, basal ganglia, thalamus, and brainstem, especially pons. So these are, until proven otherwise, are hypertensive hemorrhages. The second most common cause, I said, is cerebral amyloid angiopathy, or also known as congophilic angiopathy, older terminology. Congo red stain is a histochemical stain that stains the amyloid, and therefore people called it congophilic angiopathy. Now we have beta amyloid immunohistochemistry, so it is cerebral amyloid angiopathy. That is the second most common cause of parenchymal hemorrhage and occurs in association with beta amyloid accumulation in the blood vessels and in the brain parenchyma. There will be some reference to it in the neurodegenerative disease material, but let me briefly tell you that those hemorrhages can be multiple. If the patient survives one, there will be others, and therefore they are not necessarily synchronous, but metachronous. And therefore, you can see multiple hemorrhages at some point of different stages of evolution, and they are all superficial. So superficial multiple hemorrhages are very suggestive of beta amyloid pathology, and many of these cases are associated with Alzheimer's disease, which is a beta amyloid pathology involved process. As opposed to those, hypertensive hemorrhages are referred to as ganglionic hemorrhages or deep hemorrhages because they are in the basal ganglia.